it's funny, right? I'm the one who says you can't put things in a neat, tidy buckets. But let's just say that you're the not worried bucket, but there's tumor. Maybe you're thinking a repeat induction course of BCG. The I'm worried course is more like cystectomy should really be our top line option from a cancer perspective. Then there's the boatloads of gray. And maybe, so you mentioned gemdosi. Sounds like that's your kind of typical next option if BCG didn't work. Makes a lot of sense. A little bit trickier to give, talking about practical considerations, a couple hours, a little bit more nursing support, so on. But maybe when you're thinking about even bringing them into the clinic, so I'll throw this out there. When I think about this disease state comprehensively, you've got cystectomy, you've got pembro, you've got off-label gemdosi, you've got Adstiladrin, you got IL-15 superagonist, Activa, and we've got a couple coming through the pike that are going to be FDA approved likely within the next 4 to 6 months. Valrubicin, which I don't think anybody uses anymore, mostly of historical interest only. And then clinical trials, of course. Did I miss anything? Does it sound about okay?
Yeah, so now you're talking about BCG-unresponsive with CIS. Yeah.
Yep.
And what's interesting is, yeah, absolutely. That's pretty much the menu. And, if you have papillary-only disease, you can still get some of these things approved, right? Because they are Category 2B recommendations in the NCCN guidelines. But we really don't, it's still technically off-label, and we don't have, and that matters in my world quite a bit, because as I'm sure we'll get to, the cost of a lot of these drugs is exorbitant, right? So what we can't do in community groups like mine is buy and bill for this huge, expensive drug and then have even an inkling that it may not get reimbursed. So we are not going to go rogue and order something unless we have absolute certainty from a pre-auth specialist here that we're going to get it approved. And that's less likely if we're doing it off-label. So, but I know at academic centers, it's a little bit easier to do some of that stuff. And that it'll come with due time. And there's already been a lot of strides made for some of these expensive buy and bills in terms of getting ASP. And, there's this whole world that I have to deal with, about Medicare pass-through status and Medicare versus Medicare Advantage, all of this stuff. It's terribly boring and annoying, but it has a huge impact on patients. So once they get to be BCG unresponsive, and presumably, the high-grade T1 guy who had 6 of BCG, you can make the argument that he doesn't really meet the criteria for any of those drugs because he doesn't have CIS. He only has papillary disease. If he's got CIS and high-grade T1, it's probably a little bit easier to get him that stuff. But yeah, usually you talk now about gemdosi, Activa, Adstiladrin, cystectomy, and then clinical trials for all of your patients who have moved past all that.
Yeah, and I mean, it does seem like there's a lot more convergence than divergence between academic and non-academic. You better believe if I signed somebody up for some Adstiladrin, it got administered and we didn't get pay, Manoj would be giving me a call and asking me what the heck happened there, and he wouldn't be very pleased. And we've also got to be strategic. I mean, even just going through the process of having to go through the pharmacy, et cetera, training up personnel, it's a commitment. And while we love to have every clinical trial in every clinical space, it's also not super feasible with our limitations on the clinical research office, et cetera. So BCG unresponsive, let's just say gemdosi, that's available. There's no kind of massive cost implications to the practice.
One thing, if I could say one thing about gemdosi, which I think is important for people to hear. So community docs, the community has typically really underutilized gemdosi. It's not because we don't like it, we don't believe in it, we don't know the data. It's because it is a nuisance to give in the community. So a couple things. There's a Medicare ordinance called USP 800, which basically says that as an independent facility, you're not able to just bring in chemotherapy to your center and just give it. You have to have a certain amount of infrastructure to give. And what's going on with gemdosi is you get the bags. The gemdosi is designed for intravenous use, and then you're basically reconstituting it, and then you're giving it in the bladder, right? And so that's technically not allowed, or that is a barrier in the community. So a lot of groups historically have the discussion has been, well, you need a negative pressure room, you need a hood, you need an oncology trained RN to do all of this stuff. And it's state by state, right? So different states have different kind of regulations and how they look at all this stuff. But one of the big things with Gemdosi is it is significantly underutilized in the community because of some of these barriers. And then also you got to buy it. You have to get it compounded, which adds extra cost. You lose a lot of money on it. And so, again, we've kind of worked with, LUGPA, some of our big community urology channels. We've kind of worked to find some solutions. One of the solutions is partner with your local hospital or your local cancer center to do this. So if there are community urologists that are listening, and we get a lot of these inquiries about this, the simple answer is you don't have to do it yourself or kill yourself trying to figure it out. Partner with a local hospital or a local cancer center. They actually like doing it because a lot of them get 340B pricing and they actually can make a lot of money on some of these things. But I drafted a protocol, for example, of how to do it, how to give it, what meds to give, and I gave it to my hospital system, and so all our patients go there to get it. So that's another side note about Gemdosi, really underutilized in the community. A lot of groups are now finding ways to give it, but we have been really slow to the party.
Super practical. Totally appreciate it. I get it. Here at UC San Diego, when I started 3 years ago, it wasn't available, and it was a bit of a process because it had to be given to the cancer center, which is 50 yards away from our clinic, and it was a whole workflow things and educating the nurses over there on intravesical instillation. So one, I can appreciate that. I also appreciate the state-by-state nature of it. This is not an original idea that I had, but Yair Lotan would do office biopsies, fulgurations for his kind of chronic low-grade folks in the clinic and then just put in some gemcitabine right there. And I was like, that's brilliant. Just kind of handle it all in one go. And so I can appreciate that. And again, it's not a judgment thing. I think these logistics, maybe some familiarity are noteworthy. And